Good evening. My name is Dr. Nicole Brescia, and I am a pediatric epileptologist from SUNY Upstate Medical University. And today we're going to be talking. We're going to be talking a little bit about transitioning to adult neurology. So I always like to start off my talks with the purpose of our time spent together. So I wanted to discuss, why transition of care is important. We're going to talk a little bit about why transition is challenging for some patients and families. We're going to list out some steps for a safe and smooth transition to adult neurology care. And along the way, we're going to talk a little bit about some resources for patients and families. So I always like to start off my talks with a case. So you have Samantha. She's a 14-year-old young woman with juvenile myoclonic epilepsy. And she's had seizures since she was 13 years old. She has convulsions and myoclonic jerks that are currently controlled with the combination of Keppra and ethosuximide. So Samantha and her family, they go to their pediatric neurologist for her routine visit, and they bring up the topic of transition of care to adult neurology. So for those of you at home, I want you to think about what's going through your mind. Like maybe your doctor has talked to you about this already. Maybe they haven't. And if your doctor did talk to you about this, what would be going through your mind? What else would you want to know? So a lot of times people talk about transition of care versus transfer of care. And I want to spend a moment to unpack these a little bit. So a transition of care is a little different from a transfer of care. A transfer of care is really just about the care going from a pediatric epilepsy specialist to an adult epilepsy specialist. So it's more like here's your pediatric neurologist. Next time you're going to go see your adult neurologist, they'll read the note and then they'll take it from there. And certainly physically moving to a new doctor is part of the transition of care, but transition is a lot more than just this. Transition is more like a transformation of care, and also the transformation of the patient and the family's role when it comes to managing the epilepsy. So some examples of this include going from parent making decisions about the child's epilepsy to the child starting to make decisions about their healthcare and their epilepsy. It goes from the parent doing most of the logistics of caring for the epilepsy, like doing refills and making appointments, to the child learning how to navigate all those logistics. And then there's the care of epilepsy in a pediatric context, going to the care of epilepsy in an adult context. So, some folks, are a little bit nervous about going from a, pediatric epilepsy specialist to an adult epilepsy specialist. And that's understandable. You've been with this person for quite some time. You know each other. You know what to expect when you go see them. So it's a little bit nervous to go see a new person. And that being said, there's important things about going to an adult epilepsy specialist and important to consider. Like, there's a reason you don't stay with a pediatric epilepsy specialist forever, which is because as you grow up, you get adult medical problems that kids don't usually get, and they have to be interpreted within the context of epilepsy. You might develop new medical problems as you get older, like arthritis or high blood pressure, diabetes, and that can affect on your seizures. And there might be some new medication interactions you need to learn about, and your pediatric doctor wouldn't be familiar with those, for example. And then likewise, there are certain aspects to certain conditions, like, for example, patients with Dravet syndrome, a specific kind of genetic epilepsy, they're prone to having certain kinds of new symptoms, related to their movement that tend to happen as they get older. So your epilepsy can change as you get older and transition into adulthood. And so you need an adult neurologist who's familiar with those changes to take ownership of your care. And then, of course, there's living with epilepsy as a kid and gradually transitioning over to living with epilepsy as an adult. So this is something that has to happen as well. When you're a kid, you have epilepsy, and your big questions might be, well, how will I go to a sleepover with my friends? How can I be on the swimming team? And then as you get older, then you have questions, well, what about dating? What about driving? What about going to college? And as an adult, it's like, well, how do I tell my employer, what resources and legal protections are available to me as an adult living with epilepsy? So these are some of the examples of what transition of care means. There's a lot more involved than just transfer of care, going from your pediatric epilepsy specialist to your adult epilepsy specialist. So let's talk a little bit about why transition of care is important. So epilepsy is the most common childhood onset neurological disorder transferring into adolescence. And 15 million children all over the world have epilepsy, and that roughly translates to 5 in 1,000 kids. Now, 50 to 80% of children with epilepsy will achieve 5 years of seizure freedom. So what that means is, the majority of kids, will most likely outgrow their seizures and be seizure free for at least 5 years. Usually once you've been 5 years seizure free, the seizures tend not to come back. But that means that there's about, 20 to 50% of kids who don't outgrow their epilepsy or have a seizure recurrence, and they really will need a transition to an adult epilepsy specialist. And the other thing to think about is that nearly 80% of all kids with epilepsy have at least one disability, like intellectual disability or autism spectrum disorder or ADHD. And, so this means there's a couple considerations to think about. So it means that a good chunk of people with epilepsy, specifically kids, will require transition to an adult epilepsy specialist. And also, the majority of people with epilepsy as children have at least one disability, and that can have an impact upon on how that transition should occur. So in summary, transition of care will be needed by many kids with epilepsy. So the first step of transitioning to epilepsy, to an adult epilepsy specialist, and now we'll go through the steps for a successful transition. There's about 7 of them. And this usually happens between 12 and 15 years of age, so it's not surprising that Samantha's neurologist was talking to her about this. So the idea is, around this time frame, your child neurologist should be talking to the patient and their family about transition. What is the concept? What are the different things that entail the transition? And there you can see here, this little table outlines how that process is supposed to go, ideally. And this table is specifically for patients with epilepsy, who do not have like an intellectual disability or some sort of learning impairment that would prevent them from doing these things. But as you can see here, in the top left-hand corner, there's provider, and parent, and then youth, going from my left to my right. And you can see, the provider, has, the major responsibility, to do the educating to the patient and the family. And the parent family does the majority of providing care, and the youth is receiving the care. And then over time, the idea is the patient and the family get a little bit more independent, and the provider is, performing more of like a supporting role for the parent, family, and the youth. The patient is managing most of the care, but the youth is a little more independent, and they're able to participate in more aspects of their care. And then, they get a little older, a little bit more independent, and then the provider is like a consultant, the person that you come to and you bounce ideas, off of, to get the latest and greatest recommendations, for the care. And parent family is more like a supervisor at this point. They're making sure that all the questions get answered, that their child's getting everything that they need, but their child's really driving the bus on a lot of the aspects related to their care, like taking their medicine, as directed, with some supervision, calling for refills, making appointments, spending time alone, with their doctor to get all their questions answered. And then finally, when you're all done and ready to transition to adult epilepsy, the idea is that your provider is more of like a resource, and your patient's family is like a consultant to them, where they're bouncing ideas off of them, making sure that, they're getting all their questions answered. And the youth is, largely knows all the basics when it comes to navigating, the healthcare system and navigating their epilepsy. And, it's a progression. Everybody does the steps, at different times, but the goal is by the time people are ready to transition, they largely know all the steps that go into successfully navigating that system and successfully managing their epilepsy. So this is step 2. So this usually happens between 12 and 15. So they call this explore the supports. So this applies a little bit more to our patients with epilepsy who have an intellectual disability, who likely will not be able to make all of their decisions, all of their and participate, in all aspects of their care. So usually between 12 and 15, I usually start asking patients and families, so how would you like your child to spend their time and live their life when you're no longer, able to care for them? This is a big thing to think about, and sometimes it can be a little scary, for sure, but I also think it's important to think about, and it's definitely important to think about it early and start planning for it early before you get into crisis mode, or before something were to happen and your hand was forced to make a transition that you really weren't ready for, didn't want to. So usually in 12 to 15, it's important to start exploring what supports are available to help your child transition from how they're spending their time, as a child with epilepsy to an adult with epilepsy. So these include things like financial supports, like SSI, legal support, housing, residential placement, guardianship, education, respite care, employment. These are all important things to start thinking about, usually between 12 to 15 years of age. Like, how will we go about getting these supports, for, our child who has epilepsy and a developmental disability or intellectual disability that would prevent them from fully being able to do all these things and navigate all these things by themselves. And there's lots of resources to help. In my old clinic, we have social worker. There's also office for persons with developmental disabilities that is very good about, helping people navigate all these different aspects to care. But a lot of times, going through this process, getting those financial supports, getting those legal supports, applying to SSI, applying to guardianship, a lot of times that process can take 1 to 2 years. So it's all the more reason to start thinking about it and asking about how to go about doing it early. And then this is step 3. This is readiness to transition. Now between 16 and 17, it's important to ask, are me and my child ready to transition to adult epilepsy care? So this applies as much to the parents as it does to the patient. So usually to assess readiness to transition to adult epilepsy care, there's a questionnaire for both the child and the parent. And they both, ask similar questions, but they all have to do with questions that, ask things about what people need to do to successfully manage their epilepsy. So they include things like, can the parent and child both name the kind of epilepsy the patient has and what other kinds of health conditions they have that might accompany that, like intellectual disability, ADHD, heart problems, whatever other kinds of health conditions are happening alongside the epilepsy. They're important to be able to know how to talk about what medications are taken. What is the rescue plan? If you need to have a rescue plan for your epilepsy in case you have a long seizure or 2 or more seizures that return to baseline in between. When do you call the neurology office and when do you call 911? And how do you do that? How do you get a refill? How do you make an appointment? Another important thing is, like, are you psychologically ready to transition? Like, do both the parent and the child know how to advocate for themselves? Do they know how to ask all the questions that they want to ask in an appointment? Are they able to spend time alone with their healthcare provider to make sure all their questions, are asked? Sometimes, you might not want to talk about every single thing in front of your parents. And this is especially important when it comes to discussing, how epilepsy intersects with reproductive health and sexuality. Do the parent and the child both understand what confidentiality means when it comes to healthcare? Do the parent and child both understand, like important things about when and how to disclose the diagnosis of epilepsy to friends, people you're in relationships with, or employers? These are all, kind of important questions to ask yourself and for your child to ask themselves when they get to the stage around 16 or 17. Like, to see, are you ready to transition? And if the answer is no to some of these things, that's okay. It just means that this is an opportunity to address some of these questions and find the answers so that you, when the time comes, you will be ready for the transition. So this question is basically boiled down to, what skills will my child need to successfully manage their epilepsy? And then this is like step 4. It's broken down into 2 big things. So as kids get older and they enter adolescence, we all know that adolescence is a very busy time, both physically for the body and emotionally and psychologically. And it's important to address topics with adolescents that are important and also intersect with their epilepsy. I definitely have a lot of adult epilepsy colleagues, and they often mention to me, I really wish that my child's pediatric epileptologist had talked to them about driving before they got to me. Or I really wish my patient's epileptologist had talked to them about, about SUDEP before they came to me. Because I think these topics are too important, when it comes to adolescence and epilepsy, to wait until you go to an adult epilepsy specialist to get them addressed. So these are some of the things that are important for your child's pediatric epileptologist to address. Usually, between the ages of 12 and 19, not necessarily all at once, but over the course of this time period, it's important to get these addressed. So this is like the importance of adherence. We know that preventing uncontrolled convulsions is the most important way to prevent sudden unexplained death in epilepsy, which is what SUDEP is. And it's important to understand the definition of SUDEP, the risk factors for it, how best to prevent it, and how likely your child is to develop SUDEP. So you can understand how that does or doesn't apply to you. So it's important to have that discussion. It's also important to have a discussion about the intersection between reproductive health and epilepsy. So these include topics like how to avoid unplanned pregnancy. What is the role of folic acid in people who are able to become pregnant with epilepsy? How do you choose the right contraception? Because some of our anti-seizure medicines do have an interaction with contraception and vice versa. What are some possible negative side effects on a developing baby should a pregnancy occur, given what kinds of anti-seizure medicines your child is on? Another important thing is, to talk about driving. It varies from state to state. In the state of New York, people have to be 1 year seizure free to drive. How do people navigate dating, going to college, getting a job? When is the right time to disclose, having a diagnosis of epilepsy? And then, of course, adolescence is an important time to talk about mental health, because mental health has a huge effect on so many other aspects of our lives, as well as our physical health. And it's an important time, for your child's doctor to address topics involving anxiety, depression, and other, mental health concerns. And this is step 4B. So around age 12 to 19, we start to think about, what kinds of things could set this transition up for failure, and how do we get support in addressing them now before people go try to transition and then fail? Because the last thing we want is for people to be lost to follow-up, or to not have an epilepsy doctor to fill their medicines, or then to run out of rescue medicine. We don't want that to happen, because that can have some pretty deleterious consequences. So generally speaking, patients who have difficulty with things like keeping appointments, whether that's with a neurologist, or getting their EEGs, or getting their MRIs done, or doing blood work, if you have trouble keeping your appointments, then it's not going to get any easier when you go to adult epilepsy care. So we really want to try to address the barriers to getting to all the appointments before that happens. Also, the world of child epilepsy is changing very quickly. There is a lot more access to genetic diagnosis now than there was even like 10 years ago. So a lot of adult epileptologists are having to learn and get up to speed very quick about specific genetic conditions and specific kinds of epilepsy. So you want to think about, what kind of epilepsy does your child have? Is there a specific genetic etiology? And is there a specific epileptologist who specializes in adults who is familiar with this condition? And then, as people get older, between 12 and 19, you want to make sure that there are no missed developmental disabilities or intellectual disability that could make it hard for that person to navigate the healthcare system. Sometimes, these developmental disabilities, intellectual disabilities can go undiagnosed, and, a person can compensate pretty well up to a point, but then when they have to navigate a whole healthcare system by themselves, it can get pretty overwhelming, and that person can, be lost to follow-up. So we want to make sure that we identify the things that could set the transition up for failure and get support in addressing them early on. So then comes to step 5, getting your diagnosis right. Usually we want to think about this between 16 and 19 years of age. So some people have epilepsy starting from the first day they're born. Some people do not develop epilepsy until well into adolescence. But regardless of what kind of epilepsy you have or when your epilepsy started, you really want to make sure that your diagnosis is as accurate as possible. And what I mean by that is that you get the thing that is causing your epilepsy as accurate as possible. So if your child does not have a clear etiology, which is the medical term for cause of epilepsy, now is the time to think about how to make that cause a little bit more clear, because it is much easier to transition to an adult neurologist with a known diagnosis and to know where to pick up with the care than it is to come to an adult epileptologist without a known diagnosis and know exactly how to pick up the care. So now's the time to think about things like, do we need to recheck the EEG? Whether that's a routine or a video EEG. Do we need to recheck imaging? And this is important because when you go to the adult epilepsy care center, they might not be equipped to look after people with intellectual developmental disabilities who require anesthesia for their imaging. So it's important to understand, do we need imaging now? Will it change our management? And if so, is it most prudent to do it now, in our pediatric epilepsy care center because they might need anesthesia? And then the last bit here is exploring genetic testing. Genetic testing has changed a lot, and it's the whole topic in and of itself. In my own practice, we use a bunch of different tests, from the Invitae epilepsy panel to microarrays to whole exome sequencing. And there's lots of different kinds of genetic testing out there, and they all look at the DNA in slightly different ways. So, now when you get into this part of the transition, if your child hasn't had a comprehensive genetic workup, it's important to ask your child's pediatric epileptologist, is this an appropriate thing for my child, and an important way for us to make sure we get the etiology or the cause of their epilepsy right? And now sometimes people's epilepsy can change. Sometimes your child's seizures might have been one way for a very long time, and then all of a sudden they're having new kinds of episodes concerning for seizures, or sometimes they're having events that are concerning for non-epileptic events, or psychogenic seizures, or PNES as it's sometimes known. And when this happens, we don't want to wait until the person goes to the adult epilepsy care specialist to have to figure all this out and kind of make a whole new care plan. We want the person who knows the patient best to recheck their video EEG monitoring, to capture and characterize those events, to watch the patient have their event on the EEG, so we can decide, is it a seizure or is it not a seizure, and what kinds of changes, if any, to the medicine do we need to make. And some people might wonder, is my child too old to get a genetic diagnosis? Even as like an adult, is it too late for me to get a genetic diagnosis? And I'll say it's never too late to get a correct diagnosis. It's never too late to ask if there should be steps taken to find the right etiology, to find the right cause if one hasn't been found. Because getting a correct diagnosis, even when you're older or when you're an adult, can still really have a large impact on your management. So then we go on to step 6 here. So this is between like 16 and 17, you want to make sure that all aspects of your child's care can be continued. So a question to ask yourself is, does your child have a vagal nerve stimulator, or VNS, a responsive nerve stimulator, or RNS, a deep brain stimulator, DBS? These are all implantable devices. They are implanted surgically in different places. And they are for people with medically intractable epilepsy. That's people with seizures that are hard to control with medicine, specifically people who have failed two or more seizure drugs at appropriately chosen doses and are still having seizures. So if your child falls into that category and has gotten a vagal nerve stimulator or a responsive nerve stimulator or a deep brain stimulator, you want to make sure that you go to a adult epilepsy care center that can do these devices, and also with familiarity with these devices and how to titrate them and how to replace them. Is your child on a ketogenic diet? We have about 250 centers for dietary therapy and epilepsy worldwide. So it's important, if your child is using the ketogenic diet, to be able to go to an epilepsy care center that specializes in adults that also has dietary therapy available, and not just a neurologist who's familiar with the diet. You also need to make sure that there's social workers to help with formula refills and vitamin refills, and a dietitian who's familiar with the diet and how to make changes to it. And then when you're at 16 or 17, you also want to think, is my child with medically refractory epilepsy a surgical candidate? In general, if your child is a candidate for epilepsy surgery, it's usually better to have the doctor who knows them the best, be the person to help you navigate that surgical process. And so if your child has medically refractory epilepsy, it's important to ask their pediatric epileptologist, my child's failed more than 2 medicines. Are they a surgical candidate? And if we don't know, how do we go about finding out if they are? Because there's specific steps, and that workup often takes several months to a year, before it's known if the person is a surgical candidate. And then it takes more time to plan with the neurosurgeon to do the surgery. And in general, if someone is a surgical candidate, the sooner they have the surgery, the more likely they are to get benefit from it and have more years of freedom from disabling seizures. So you want to just make sure your new epileptologist has the experience and access to the resources to carry out these specific treatment modalities for people with medically intractable epilepsy. So now there's step 7, tying it all together. So around 17 to 18, by now, people should have been assessed for transition. They've talked about, living with epilepsy, about what steps need to be taken to ensure a transition to adult epilepsy care, and how to live life independently with epilepsy or with supports in the case of those with epilepsy and developmental or intellectual disabilities. And around 17, as you're getting ready for your transition to adult epilepsy care, you want to have what's called a pediatric discharge package. So the pediatric discharge package has a couple different things in it. It has an epilepsy history. So this is going to be things like the age of onset of your seizures, what your seizures look like, also known as the semiology. How frequent are your seizures? When was your last seizure? It's going to have things like what are your current anti-seizure medications? And what were your prior anti-seizure medications? And how high of a dose did you get up to on those medications? Why were those medicines stopped? Did they fail? Did you have side effects? And this is really important because adult epilepsy care providers don't necessarily want to reinvent the wheel, and they certainly don't want to expose you or your child to medicine they've already tried and hasn't worked for them. So it's why it's important to have the current anti-seizure medicines and the doses, and the previous anti-seizure medicines and their doses. And it's going to have things like side effects from anti-seizure medication. It needs to have things like historical information about the epilepsy, like what kinds of risk factors for epilepsy does your child have? What is their prenatal and birth history? What has their developmental history been like? And then we need to know things like the workup, what previous EEGs have been done, what previous MRIs have been done, what kind of genetic testing was done, What sort of neuropsychological assessments have been done? What kind of mental health care has your child had? And what kinds of, conditions regarding mental health is your child coping with? Depression, anxiety, schizophrenia, all that kind of stuff. And and then also any modalities for medically intractable epilepsy, like vagal nerve stimulator, RNS, DBS, ketogenic diet. Your epilepsy history is gonna need to have all those things. And then there's goals of care. Ideally, everybody would be seizure-free with minimal or no side effects. But we know that for a lot of people, that's not, a goal that can be achieved due to the cause of their epilepsy or because of the kind of epilepsy they have. So it's important to have the discussion of goals of care with your pediatric neurologist so your new adult epileptologist can know them. So for example, some people have epileptic seizures and non-epileptic events. It's very important to describe what are the epileptic seizures, because those are the ones that your epileptologist is going to want to go after and treat. And what are the non-epileptic seizures? What do they look like? And how are they addressed at work or at school? So that, so that your pediatric neurologist has that information about the non-epileptic events and knows not to pursue them and chase after them with increasing medication doses. What is your rescue plan? For example, do you use rectal diastat or intranasal midazolam or buccal clonazepam? And when do you use those medicines? And when do you use those medicines versus, calling 911 and going straight to the hospital? What kind of community and financial and legal supports do you have for your child in place to help them navigate the healthcare system and navigate living with epilepsy? Your pediatric epileptologist should include those readiness transition screening tools so that the adult epileptologist can get an idea about where is this person at in terms of their readiness to transition. What kinds of skills do we need to empower this new patient with? And what are the psychosocial screenings? Are there any mental health concerns? And are there any potential barriers to care that need to be addressed so that this person can successfully come into our new practice as an adult epilepsy patient? So there's a lot of players to this. They include your pediatric epileptologist, your adult epileptologist, your primary care provider, because a lot of people with epilepsy don't just have an epileptologist, they have a psychiatrist, they have a social worker, they have a developmental pediatrician, they have a physical therapist, an occupational therapist, and your PCP needs to help you make sure that all those other referrals go through and are accepted. Social workers and other specialists, they all, when you start thinking about transition of care for your child who has epilepsy to an adult epilepsy care specialist, it also means thinking about transitioning to adult care providers for all these other things too. And these are my references. There's lots of resources out there to help people with transition. The Child Neurology Society has a whole statement paper that these 7 steps are based off of. There's also the National Epilepsy Foundation, which has resources on how to transition. They even have comic books, like little web comics showing a teenage patient like learning about transitioning to adult epilepsy care. Office for Persons with Developmental Disabilities is another important resource. And if anyone else in the audience knows of any of the resources that have helped them and would like to share, that would also be wonderful to hear about. So I thank you all very much for your attention, and I look forward to taking your questions.